Well, that's because I have actually the honor of being here with a very special company and two surgeons that I think are some of the top surgeons in the US that are dealing with our topic today as well, which is going to be, of course, breast cancer and what's around that. So I'm very, very privileged to have you here, and I actually will do my best. I will talk to Jeremy about it later on, to also have another discussion at our family office conference is coming at the end of the month. So this is not a normal hour for us, and yet many people registered, which I think shows people's obviously interest, and we have again very special guests. I'm never around so many doctors. The last time I was around so many doctors was when I spoke at the World Stem Cell Summit. I was the only guy who didn't understand anything that went on. Like all the topics of the presentations said nothing to me, because I spoke about how life science companies should approach family offices. Anyway, let's get down to it. I think thank you for being here. I think Dr. Ted just got right now out of from the hospital, right? Just from another surgery. Yeah. So let's do a quick. It's not going to be quick because their bios are so impressive. But I will start with Dr. Ted, a member of the BIDMC Harvard Health System. Dr. Ted James manages the surgical care of breast cancer patients. He performs advanced breast surgical oncology procedures, including oncoplastic and minimally invasive breast surgery. I managed to pronounce most of the sentence. Dr. James also takes an active role promoting quality initiatives in cancer care delivery. He's active in research on improving outcomes in breast cancer surgery, including margin control during breast conserving surgery. Dr. James employs a team-based approach to cancer care and believes that patients should be key members of the treatment decision-making process. He educates patients about their diagnosis and addresses their treatment priorities. He believes that care must also be compassionate and focus on the entire person, including their physical, emotional, and spiritual well-being. Dr. James obtains a healthcare management degree from Harvard, is also faculty at Harvard Medical School. I hope I didn't leave anything out. Dr. Frank Prendergast has held, thank you, held senior positions within Mayo Clinic, Chair, Department of Biochemistry and Molecular Biology, Director for Research, Mayo Clinic, Rochester, member of the Board of Governors for Mayo Clinic in Rochester, Mayo Clinic Board of Trustees, Mayo Clinic's Board of Governors, Mayo Distinguished Investigator, Emeritus, Director of the Mayo Clinic Comprehensive Cancer Center, and Director of Mayo Center for Individualized Medicine. He also served for the National Institute of Health, Board of Advisors for Division of Research Grants, National Advisory, General Medical Sciences Council, Board of Scientific Advisors of National Cancer Institute, National Cancer Advisory Board, received honors and awards such as Rhodes Scholarship, Purdue University, and University West Indies. By the way, in 2 weeks, we're going to have the Purdue family at our Canadian conference. Outstanding graduate from University West Indies, outstanding graduate College of Biological Sciences from University of Mainz. Well, it's one of the most impressive bios I've read as well. Jeremy Sobotta, President and Chief Financial Officer at Perimeter Medical Imaging AI. Prior to joining Perimeter as its Chief Financial Officer in December 2019, he was the controller for the orthopedics division of Smith and Nephew, and held roles of increasing responsibility at Stryker, including internal audit, finance, transformation, commercial excellence, financial planning and analysis, and eventually leading finance for their surgical business unit. He brings to the role diverse medical device commercialization experience, having lived and worked in North America, Europe, and Africa, supporting commercial organizations across a wide range of medical technology, including capital equipment, robotics, and implants. Wow. Wow. And I'm Danny Sherrod of DC Finance from RAI, and I'm very honored to be here and lead the discussion, which is the physician's perspectives about improving breast cancer outcomes with Perimeter's disruptive medical technology and AI. So, hey everybody, hello and good afternoon. And where are you at right now around the world?
So I'm in Boston right now, Boston, Massachusetts.
And I'm in Broomfield, Colorado.
And Dallas, Texas.
Dallas, Texas, one of our favorite destinations for our conferences. Today's discussion provides us with the unique opportunity to speak directly with two prominent breast cancer physicians and hear their thoughts on an innovative, disruptive technology that is poised to change the breast cancer surgery space. To help set the stage for today's discussion, I'd like to ask Jeremy to provide a brief overview of Perimeter Medical, its unique technology platform, and the problem Perimeter is addressing. But before that, I would just like to ask all of you, obviously, it's a question we're asking everybody we talk to about how does COVID affect your life? What do you see around you? Obviously, it changes the world. And later on, I would ask how COVID affected your Perimeter's work or not. But yeah, so that's my question just before we dive into to Perimeter.
So, Denny, I take you wanted me to just make some comments. This is Frank Prendergast. Let me tell you a little bit more about myself because it's relevant here. I'm from Jamaica originally, then via England to Mayo Clinic, where I spent my entire career. Since I retired from Mayo in December of 2014, I've been living in Colorado, but I still maintain close connections with my alma mater. But recently, back in March, I contracted SARS-CoV-2 virus, in other words, COVID-19. And let me just tell everybody who is on the line, this is not a little flu. This is a miserable, miserable virus. It's easily the most ill that I have been. And I was acutely ill for about a month with just about every symptom that you've heard of. And then subsequently, I've been a long hauler. It's taken me 5.5 months to 6 months to recover to a state of complete health. I lost 10 pounds of weight in 9 days, and I had just about every miserable cardiac symptom you can imagine, and pulmonary symptom as well. So it's something to take very, very seriously. And if you'd like to have more discussion, we can do that after our breast cancer discussion this afternoon. The critical issue for this disease is how stealthy it is. Because you can be asymptomatic for quite a while, and then all of a sudden, wham, it hits. And the other thing, it tends to be biphasic, meaning that first phase can be quite mild, maybe a cough, and pretty miserable cough. Then there seems to be a period where you feel better, and then all of a sudden, it hits you like a bomb. And that was my course of action too. And if I hadn't been this typically stubborn physician, I might have been where I should have been in the hospital. So I just want to tell everybody out there, I'm proselytizing for the health experts in this field in public health. This is a very serious disease. Try to avoid it as much as you possibly can.
Thank you. Yeah, so I actually, yeah, thank you for sharing that. I just heard that several minutes ago, and I thought this is something worth sharing with our audience here. So, yeah, so back to Jeremy, if you can, provide us with an overview of the company and your unique technology platform.
Yeah, great. Thanks. I'll keep our intro brief as today's call is about the patients and about hearing direct from two physicians that are talking about how our technology can impact those patients and help improve outcomes. But Perimeter Medical Imaging AI is a commercial stage medical device company. We're kind of right at a very exciting time of our life cycle where we're transitioning from late clinical stage into commercial efforts on our already FDA cleared imaging platform device. So our novel technology is addressing an unmet need in breast cancer surgery, which is intraoperative margin assessment. And I'll let the physicians talk us through that in a little more detail. But our technology is providing surgeons with new tools to be able to visualize the margins intraoperatively and assess whether or not they need to take additional tissue from a patient in the first surgery, which today is many, many times not identified until days later, requiring second costly, inconvenient, problematic surgery to go in and remove additional tissue. From an exciting kind of product development perspective, we have just kicked off a clinical study to further train and test an artificial intelligence algorithm that will overlay the images that our machine generates and really provide a kind of a Google Maps that would say, hey, review this part of the image because the image has characteristics that would indicate that tissue is suspicious for containing cancer cells. So this is really the intersection of phenomenal innovation in surgical intervention combined with big data and unstructured data that we could not be more excited about. And we've just recently completed a reverse takeover to be listed on the Toronto Stock Exchange under the symbol PINK, so pink, which is exactly why we're doing this call during Breast Cancer Awareness Month, because that is what we are trying to improve. And we came out of that well capitalized and are really looking forward to finalizing those commercialization and product development efforts, as well as starting our commercial sales force for the existing technology.
Great. Canada is one of our favorite markets, by the way. Breast cancer is such a widespread global problem impacting approximately 2 million women worldwide. And cancer left behind after surgery creates the additional problem of reoperations. I understand that almost 1 in 4 lumpectomy surgeries require reoperation. Doctors, please tell me if you can give comments on the negative consequences of reoperating and how this impacts both patients and healthcare providers.
Ed, you should take that.
That one. So the negative ramifications of a positive margin we're talking about is, the concern that not all the tumor has been removed. And what happens with that is it has many, many, many negative consequences. First and foremost, it's often a very devastating finding for the patient because it means that they're going to have to undergo additional surgery. So another anesthetic, another day off from work, going through the discomfort of surgery, recovery once again. I think psychologically for many women too, the concern is that the cancer was something had to be very bad about this cancer that it couldn't be removed in one operation. And sometimes I'll have patients who want to have the entire breast removed after they hear they have a positive margin because it's such a stressful and emotional situation. I think from a surgeon's point of view, all surgeons strive to be perfect, right? So anytime that you have a finding that says that you need to redo your operation, it's very I think difficult for most surgeons. It's something that we want to avoid because we're trying to do the best for our patients. But there's also logistical issues there. There's time to get the patient back into surgery. That's now another patient who might be waiting longer for their operation. And oftentimes after these procedures, there are other very important treatments that need to happen. They need to have radiation therapy. They may need to have chemotherapy, and those things now get delayed because of the need for more surgery. There's also the higher risk now for infections and other complications, and then the financial costs, both to the patient in terms of loss of productivity, co-pays, but also costs in terms of the system, right? So this is not a highly efficient scenario if this, 25% of women or so need to undergo a reoperation. So on multiple levels, from the health system to the kind of quality improvement, physician practice, and patient experience, there are negative consequences of positive margins. And we also know that with positive margins, need to do re-excision, there's always the risk that there could be residual disease, and that has a whole nother host of potential complications with the risk of recurrence and ultimately affecting prognosis.
Thank you. Can you provide your perspective on how Perimeter's technology differs from the existing techniques and technologies currently used during breast cancer surgery, like X-ray or ultrasound?
So Frank, I'll let you jump in. I have some thoughts there, but I know you have some
Yes.
work on that as well.
So just a little personal note, Ted, to add on to what you just said. In my family, on my mother's side, I had 5 aunts plus my mother and 2 uncles. So 8 sibs in all on my mother's side, and all 8 of them died of cancer. What is interesting is that of the 6 women, my 6 aunts, my mother and my 5 aunts, 5 of them died of breast cancer and 1 died of ovarian. And Ted will immediately recognize that there's something genetic going on there.
Absolutely.
What was particularly traumatic was for my mother, she discovered her breast cancer as a consequence of an accident, a car accident. And she was seen by a physician just checking her out after the accident, discovered this lump in her breast, which turned out to be a stage 3 breast cancer in final analysis. The initial surgery was done, and she didn't realize that she had positive margins until 2 weeks after the surgery was done. She was reoperated on. But interestingly, it appears, because I was fairly young at the time, it appears that this was a particularly aggressive cancer. And somehow it seemed to grow more quickly after. This was in 1969. It seemed to grow much more quickly after the surgery, which is a fairly well-known phenomenon. And we didn't have the diagnostic tools at the time. So she succumbed just 6 months after the reoperation. But this is a personal issue for me. I became director of the Cancer Center at Mayo in 1994 and was there through 2006. And the whole question of reoperation was a central issue. And Ted may know, because one of the things people wouldn't realize is, or won't realize, is that Mayo's reputation as a surgical center to a great extent started with breast cancer. And they developed a technique called frozen section pathology, where the tumor is excised and then sent to a lab. And within as short a period as possible, the pathologist would take a section of the tumor, stain it with methylene blue, and then look for the margins of the tumor to see if they were positive or not. Mayo became very famous because of that. And there are many other things too. But breast cancer contributed substantially to the development of Mayo Clinic. And when I went there as a resident, that was drummed into my head immediately. I was a resident in internal medicine, was drummed into my head immediately. How important frozen section was, how important the technique would be for all of cancer, but especially for breast cancer. So I have a very personal history of all of this. So the way, Ted will tell you this, he's the arch surgeon here, not I. And he'll tell you that his fingers played a major role in trying to find, initially at least, the margins of a tumor. That's fairly typical. My brother was a surgeon, and that's what we would do. We'd feel that, see if you could detect the margin, but of course that's very imprecise. Frozen section is a big advance. But if you think about what happens around the world with less skilled surgeons, less skilled technologies available, especially even here in the States or in Canada, with a lot of the surgery being done in community hospitals by perfectly capable surgeons, but lacking the democratizing principle. That's where I think Perimeter really fits in. The technology uses light as a tool. It's called optical coherence tomography. And it uses light as a tool to interrogate the tissues and differentiate the normal tissue from the diseased tissue. And the resolution of that technology is very high. Moreover, since you can add techniques like artificial intelligence or augmented intelligence, you can do what is called training the system. You can teach the system how the distinction between normal and diseased tissue is reflected in the image. You can interrogate the image in 3 dimensions, and you can section it optically using light to do the sectioning in such a way that the resolution of your sectioning is very, very fine, certainly infinitely better than your fingers. But the most important thing is that the technology is essentially automated. So once you have excised the tissue, you send it to this instrument, it tells you that the margins are either clean or they're not clean. You can then go back, because you have all the 3-dimensional coordinates, you can go back and find out exactly where you need to excise more tissue until the margins are reflected to be clean. So light is a much better discriminator than your fingertips. It can be automated. It can be therefore distributed to community hospitals, not just in the States or Canada, but all over the world. And Jeremy Sobotta reminded me of a word that I am very fond of: democratization of skill. So that the surgeons now can add to their own capabilities this tool, which makes them much better surgeons and therefore benefits the patient, as Ted says, remarkably.
Can you expand? I'm sorry, Dr. Ted, did you have anything else to add here?
No, I think that's a wonderful way to encapsulate encapsulate what this device does. It really it enables surgeons to do a better job caring for patients with breast cancer. It's something that there's been a need for quite some time, as Frank described. Most institutions don't have frozen section. Most institutions don't have the infrastructure, the technology, the skill, the personnel to do that. So to have this cost-effective and efficient device that can allow any surgeon to improve the quality of that operation is something that's been a long time coming. It meets a very important need in breast cancer.
Are there any other advantages that you think we should mention here, or you covered it all, of being able to use this tool during the operation, and how it could potentially change tissue assessment workflows in cancer surgery? Is there anything?
Yeah, it's hard to add to Frank's story because he gives such a great overview and illustration. But what it does, again, is at the time of surgery, it gives you the information that you need to do an appropriate operation. Okay, it gives you the information that you can actually identify if there's more work to be done, not a week later or 2 weeks later, but right there in the operating room where you can actually use that information on the spot. So what that does, it makes things much more efficient because it reduces re-excisions. It makes things much more efficient because patients now can get on with their other therapies, radiation, chemotherapy, things of that sort. And there's just a benefit in terms of reducing costs all around. One of the things that we're seeing in healthcare now is this slow trend towards value-based healthcare, where more and more accountable care organizations and healthcare systems and healthcare networks are being held accountable for cost. So no longer is it just, you get to bill for whatever you do, but you're actually now looked and held accountable for quality and outcomes. So I think there's even greater emphasis now. The timing right now from a healthcare policy and healthcare regulation and payment is ideal for this type of device. I mean, let alone being the right thing to do, obviously, there is now more and more of a financial incentive for a healthcare organization to be able to deliver high quality, and that's exactly what Otis does.
And can you define DCIS, and can you speak to how DCIS patients in particular would benefit from improved margin assessment during surgery?
Ted, that's you again.
Sure. No, I'm happy to tackle that. So DCIS is particularly tricky. So DCIS, basically ductal carcinoma in situ, it's a microscopic disease. It forms inside the milk ducts. It's typically not palpable. So Frank talked about your fingers. You can't feel DCIS typically. You can't see it with your naked eye. And if you look at the cases where people do lumpectomies and have positive margins, right? So you take out the tumor and then you get your report back a week or two later, and they say that there's cancers at the edge of what you remove, which means, there could be cancer left in the patient. You need to go back again. The vast majority of cases, what they find at the edge is DCIS, this microscopic disease, because it tends to extend away from the central mass and be in the peripheral areas. It's so tricky that you actually don't just want to have a clean margin. With DCIS, you actually want to have about 2 millimeters of a safety between the DCIS and the clean edge of the tissue. And the thing that's amazing is that with the perimeter device, it gives you that 2 millimeters depth of penetration. So you can actually tell whether or not you have any of this very pesky, very, very annoying DCIS that tends to lead to re-excision anywhere near within 2 millimeters of your margin. So this actually now meets the standard of care because 2 millimeters is the defined criteria of how much normal tissue you need to have for DCIS. So as much as that this is revolutionary for invasive breast cancer, it's even more so for non-invasive or DCIS, ductal carcinoma in situ.
Yeah, thanks for that, Dr. James. So maybe just to pile on a little bit too, and Frank focused on how much higher fidelity and higher resolution using light is instead of using your fingers. Well, some of the trade-offs are that you can't go as deep into the tissue as other imaging modalities like an ultrasound or something like that. But because we're zeroing in on that 2 millimeter area of the tissue, this is the perfect use case for OCT for that very reason. And we're able to zero in on that area and give, cellular level resolution to review those areas, which is, couldn't be better suited for our use case.
Now we've been focusing on the core imaging technology, but I understand that Perimeter is also developing an AI component to further assist surgeons. Applying AI to medical technologies is an exciting theme that is getting a lot of attention from investors and healthcare providers alike. In your opinions, what are the real advantages of incorporating this type of machine learning into this new technology? And how will it impact the adoption of this technology more broadly?
Jeremy?
I think that's for you.
Yeah, so I'll set it up. So the technology, as we mentioned earlier, is really exciting because it's going to accelerate users along the adoption curve. So instead of somebody learning a new imaging modality and learning how to review examples of images like DCIS or like invasive cancer with our tool, this provides them an acceleration of zeroing in on parts of the images that are generated to help them focus on the important parts of the margin. And then, so as it impacts adoption more broadly, the output of our machine is a lot like other imaging modalities. So we believe there's a great cohort of surgeons that will be early adopters for us, that will be part of this initial commercialization path on the pre-algorithm device that we have. And that's the imaging savvy surgeons that won't have too steep of a learning curve to pick up OCT kind of images. But once we have the AI, that's when it really gets democratized, as Frank mentioned, and it can be proliferated into 100% of surgeons, even your general surgeons that aren't doing near as many breast cancer or breast lumpectomies as the highly skilled surgeons are. And we're really excited about bringing that technology to those users and impacting those patients.
Let me add something to that. AI is all the lure at the moment. People are applying AI to better fix airplanes. And one of the realities about AI as a tool, as a computing tool, is that it really does depend on machine learning. You train your computer to learn from every next image. And so there's a thing called a training set, where you take a number of images. Let's say you have 1,000 images, and you use those to give the machine the insight into what really constitutes the margin. Where's tumor, where's not tumor. But even I spent my whole life working with optical physics, if you wish. Much of my research, my own research, was in optical techniques, mostly fluorescence, etc. And one of the realities, even with light and the fine discriminating capabilities you have with light, is that you get a phenomenon called scattering. And that is actually a feature of the OCT technique itself. But it does potentially introduce error. And the way you get rid of the error is by taking as many images as possible, comparing them using computer algorithms, and finding out what is true signal from noise. And therefore, your imaging becomes better and better and better. And especially where you're using a technique like OCT, you take as many images as possible. You integrate these over the many, many patients that you have. And it doesn't matter what the color of your skin is or whatever have you. It even doesn't matter to a certain extent what type of malignancy it is, exactly precise so-called histological type. It just matters that there's a difference between the malignant tissue and the normal tissue. Beautiful thing with this technology is the imaging process is so fast, relatively speaking, that you can take a lot of images, not just of a single tumor, but of many tumors over many patients. And the technique gets better and better and better at making the distinction between normal and abnormal tissue. So these training sets are huge. And this is where very early on in Perimeter's life, even before Jeremy, but Ted was there. And let me just point out to the audience that Ted James has been there from the start with this technology. His insights and capabilities have been absolutely dramatically important to the development of Perimeter's tools. But very early on, we talked about this being a wonderful approach for AI to increase the excellence and quality and accuracy, especially the accuracy of the technology. So AI is not just something we decided, you know, because it sounds sexy to put in with the tool. It's an essential component. And I am trying to think of, and Ted, maybe you can help me here. I can't think of, well, I think MRI imaging probably would be as accurate in the final analysis, but an MRI machine costs a lot of money. You can't do it in the operating room. It takes a lot of time to acquire the images. And in the final analysis, I do not believe it's going to give you any better resolution. So this technique is perfect for the operating surgeon.
Absolutely.
Yeah, and actually we have 100 times higher resolution than MRI. So thanks for setting that up, Frank. And then, so there was some chat on the frozen section, piqued some interest from your conversation, Frank. And you know, maybe if I could ask both of you to comment on one of the things we believe is that, you know, especially once we have the artificial intelligence, we're able to get a lot better coverage than you would get with frozen section because of the limited sample size that you're able to put on the slides and review intraoperatively for frozen section. Could you maybe compare and contrast some of the benefits of our technology versus that?
Well, as Ted says, you know, it was interesting as a resident in Mayo. We were introduced very quickly because all medical residents has to do rotations with surgeons. And we learned very early on about frozen section. But we have what is called the bench. So the surgeon would excise the tissue. It would immediately be taken by a nurse and rushed to the bench, which is the pathology bench. They would freeze the tissue. Then they would take what is called a microtome and section the tissue, stain it, and then you'd have a series of pathologists, not just one or two, but several, who would look at the tissue under a microscope. And Mayo has developed the art to it really is a fine art at Mayo, but the technique is basically miserable. It is difficult to do except if you're very, very well trained and experienced. So we had a lot of pathologists who would come to Mayo to learn how to do frozen sections. Even then, the specialized capabilities that you need to do this, especially quickly and in high volume, is just so burdensome for most institutions. It is not a technique that lends itself well to a community hospital, for example, or even to other major medical centers.
Frank, I think beyond Mayo, I think there are only maybe one or two other cancer centers in the U.S. that I'm even aware of that routinely does frozen.
That is correct, Ted.
I think the vast majority of academic and community centers don't employ frozen section for breast.
That is correct.
Great, that's very helpful. And maybe that prompted another thought from my perspective, and Ted, you talked about it a little earlier. What do you think about the advantages of maintaining orientation from the specimen with our technology, having the information right there in the surgery, in the operating room?
Yeah, no, that's a good point, Jeremy. You've heard me mention this before. You know, when you're going back in to do a re-excision, the challenge is now to identify the area specifically where that positive margin was adjacent to. And you're not looking at a perfect cube, you're looking at an irregular circle, if you're lucky, you know, that's now has inflammation and scarring. And, you know, certainly if, you know, nowadays we're doing a lot of procedures where we're combining the lumpectomy and doing a plastics procedure to maximize the cosmesis. I just did that today, actually. That's where I was just now. So I did the lumpectomy, and the plastic surgeon now is doing a bilateral breast reduction. So all the tissue is rotated and turned around. And that's just a nightmare for a positive margin, because if you have to go back a week later to try to figure out where that, let's say, medial margin was in this kind of, you know, scarred and rotated and revamped tissue, you know, it's a what's the word I'm trying to look for? Yeah, the fancy term for best guess, right? So it's your professional, your best professional expertise to try to estimate where that is, but it's really your best guess. Now, if you have that information at the time of surgery, I've just taken out the specimen and I'm scanning and it's telling me that that lateral margin is positive. I know exactly where that is, right? The breast is open, the wound is open, nothing's been changed or altered. So that's your best bet at getting a true re-excision. So again, the other benefit is doing it at the time of the original surgery.
And how easy do you think it would be to teach surgeons to use this technology as experts that have been using ultrasound and other imaging tools? How easy do you think they could be trained?
Yeah, it's a really good question. I don't think it's too difficult at all. I think a lot of surgeons were used to looking at images. We're looking at, as Frank said, preoperatively, we're looking at MRI images. A lot of surgeons use ultrasound intraoperatively. It's interesting just how similar the images are to ultrasound once you're familiar with that. So I think right off the bat, about half the surgeons out there who are doing breast will be very familiar with imaging interpretation. And by half, that's probably underestimating. But for the others who don't, I mean, the training algorithm, and again, this is where I think this is, Perimeter's done a great job, but the training algorithm that they have allows even the novice to really ramp up that learning curve quickly. So within just a few cases, they'll be able to interpret these films. And there's a lot of support along the way from people who have, you know, really developed a lot of expertise in interpreting and reading these. So even prior to developing expertise, there's going to be support for them along the way. But yeah, it's a rapid learning curve. And again, looking at the images, it's very intuitive to get the sense of where things are. And that's even without the AI. I think the AI will just, you know, be a whole nother story in terms of analysis. But even where it is right now, it wouldn't be very difficult for surgeons to learn this at all.
I see a question for Dr. Frank here. If you had to take an educated guess, do you think your technology can take the re-excretion rate down to 5% from the current 25%?
Based on first principles, the answer is yes. Is it there yet? I don't know. I haven't seen the most recent results, but I think the interposition of AI on the basic optical imaging tool, I think it is possible to do that. I've been trying to rack my brain to see if I know of any other methodology. Ultrasound won't do it, just on first principles. MRI won't do it, again, for all sorts of technical reasons. You have to have an optical tool to be able to do this. And it really depends on the accuracy of the technology. So if the margins are intrinsically fuzzy, the AI will help you to resolve that particular problem. I think it is possible. Ted, you should answer that question too. What do you think?
No, I think it definitely has the potential to do exactly that. I think certainly it has the potential to reduce any surgeon's positive margin rate, I would say at least by 50%, easily. And again, there's a lot of surgeons who may not be doing this procedure frequently, where I've seen rates even higher than 25%, some as high as 40% actually in some practices. So I do think that this has the ability to significantly improve any practice's positive margin rate, and potentially even go down to 5%, or, you know, Denny, I mean, even potentially lower, right? The ability, I think, to scan the tissue intraoperatively and allow a re-excision at the time of the initial surgery, you know, we could nearly eliminate re-excisions using that type of technology.
I think that's exactly correct. Denny, I've been trying to think of what our re-excision rates, Ted may know this answer better than I do actually, at Mayo are. They're very low. I think they're probably between 5 and 7 or 8%. Do you know the figure for Ted?
I'm trying to think about the last time I saw the published results. I mean, Mayo is going to be a little lower than most of the country because of the use of frozen section.
Yeah.
So I guess what it is that this would allow everyone else to get the same results that Mayo now. And I wonder, Frank, even you would be the best one to say, if Mayo had access to this, would they forego the frozen? Because again, it's so laborious, right? So personnel and cost intensive. This may be an attractive alternative even for those who already have frozen section.
Heresy. Heresy.
Well, but hold on for a second. But Frank, think about it. If Otis was used for breast, it would free up the frozen room for the esophageal resections, for the gastric resections, for the colorectal.
Absolutely. So I'm saying heresy out of jest, because in fact, one of the people who early on consulted for us is one of the principal. In fact, he's in charge of the frozen section lab at Mayo, and he was eager to participate, especially early on. I visited with him last week on the telephone because he's both a friend and a scientific colleague. And he is very eager to re-engage with Perimeter. So, you know, Mayo's ethos, by the way, is worth talking about here, because it's a remarkable institution in a number of ways. And I'm not just saying that because I worked there for 45 years. The whole emphasis really is on what is best for the patient. At first, I thought that was just hearsay and just a typical institutional lore, but it isn't. And if they find a methodology that is better than what they can do, either for cost reasons, but mostly because of what is benefiting the patient, they'll adopt it.
Right.
I remember when I started my residency, two things. One was the incidence of surgery for peptic ulcers.
Mm.
And when, you know, Marshall in Australia came out with the notion this was caused by a bacterium, at first there was a lot of skepticism.
Right.
Then the people realized it was true, and there went peptic ulcer surgery.
Mm-hmm.
Just overnight, we changed. And secondly was the introduction of lithotripsy for kidney stones. I'm a personal beneficiary of that because I have had 7 kidney stones. Mm. And I'll tell you, it's a lot nicer to get a lithotripsy operation, or even percutaneous lithotripsy, where they actually make a hole into your kidney, than it was to do an open excision to get a stone out. Mm. And that technology was adopted very, very quickly. Similarly, Da Vinci for prostate surgery.
Right.
So I believe strongly, I'm not going to make a commitment. I can't because I no longer am at Mayo, but I still have colleagues there. And if I get sick, that's where I'm going to go. They will adopt this technology if it proves itself. And I think it's well on the way to doing that. Yeah. And one last thing, you know, people on the phone may not realize, but typically new technology in medicine, it takes somewhere between 12 and 17 years for it to become adopted. I'm going to make a prediction here now. You can hold me responsible for this at some time in the future, that this technology won't take 17 years. And I've spent a lot of time in the Middle East over the last several years. And they have the advantage, which is an interesting advantage, of being able to leapfrog a lot of technologies that didn't work and go straight to technologies that do, which is an advantage for them as they reestablish their medical system, for example, in UAE and in Saudi Arabia, where I've been. So I'm going to push for them to take a good hard look at this and go from where they are now, where their excision rates are very high, as I recall, to a modern system where they will have very low re-excision rates. I think this is going to be true of the whole developing world.
Yeah, I think the floor is right for that right now. You know, we talked about the value-based healthcare initiatives. There's also just the the competition, right? The competitive advantage of being able to offer or promote or market that you have a device that's going to do a better job for breast cancer. And breast cancer is such a prevalent disease that most institutions do manage breast cancer patients. And again, being able to have something that you can inform your patients about that will actually do a better job of their operation. I mean, if you were a patient, you had a choice between going to a practice that had a 25% chance of having to have more than one surgery, or a device that almost completely eliminates the possibility of having more than one surgery and just having it done correctly the first time. I mean, where would you go, or where would you send your loved one? And then from the patient experience point of view as well, it's another major driver in healthcare now, is that we really are looking things from the patient's point of view. And one of the things, if you look at patient-reported outcomes after breast care, and we're actually doing some studies to delve deeper into this, but having to go back again for re-excision turns out to be a much more stressful and long-acting point of distress for patients. Where years after treatment, one of the things that they remember is having to go back in for more than one operation. So sometimes we think, oh, what's the big deal? You go in, it's a 1-hour procedure, you get back out again. It's a little bit of discomfort and recovery. But no, to the patient, this is a major detractor from their overall experience of care and satisfaction. So I think these three things are making this device very timely for, as Frank said, a rapid adoption into clinical practice.
Now we have a couple of questions here. I see people are interested in the IP side of things, asking, do you have IP of the optical process and or the AI process? And another question, can you please discuss the defensibility of the company's intellectual properties? Could a competitor copy what is being done?
I guess I'll take that one. Yeah, so we do have a very robust IP portfolio around the technology. So a couple of points there. One, OCT technology is a very mature technology. It's widely used in ophthalmology and cardiology. So we're not novel in the sense that it's some university laboratory technology that we're just trying to get adopted. It's proven in the medical field and proven in the imaging field specifically. Our innovation to the space has been taking what would otherwise scan a 1 by 1 centimeter of your retina and making it wide field so that it can scan the size of a lumpectomy specimen and do so in real time. So we have intellectual property around the image generation, around the image processing. And then, as Dr. James mentioned earlier, there are a fair amount of challenges in working with these excised specimens. They're oddly shaped, very fatty, hard to deal with. And so we have a single-use per patient consumable that is kind of the razor blade of our razor blade model that solves a lot of those problems. And it immobilizes the tissue. It ensures that you get a clean scan of light to penetrate the tissue, and ensures that the resolution that we want, that the surgeon needs, shows up on the screen and there are no distortions. So we have intellectual property around the single-use consumable that makes the whole procedure work. And then because we own the intellectual property around the image generation, it is proprietary and trade secret, all of the images that can train an artificial intelligence algorithm. So we are years ahead of anybody else being, well, one, it's defensible that they can't create the same images because of our intellectual property. And then two, they would have to amass, the same kind of volume of images as us to try to train another algorithm. So there's both patent protection and proprietary trade secret protection as well.
As expected, this is a very interesting topic, and I hardly reached the half of our questions. And people have some interesting questions here that I'll, ask. Do you guys have plans to bring the technology to the UK?
Yeah, that is certainly in our plans. Our resources today are focused on FDA clearance and commercializing in the US, just given the size of the market and the opportunity there. But once we achieve that milestone, we'll then move on to CE marking and Health Canada approval and international expansion.
Now, how many women have to get re-excision surgery every year in North America? I understand there are about 200,000 every year in the US, and 25% need re-excision surgeries, meaning about 40,000 women. Wow, shockingly high number, which really humanizes this problem.
Right.
So how many women have to get this kind of surgery every year? And I'll ask maybe a question as well.
So if you look at the if you look at the numbers, right? So 200,000 roughly breast cancer annual cases a year, and that changes a little bit from year to year. Right now, about 70% of all women are able to have a lumpectomy. 25 to 30% will need a mastectomy. About 70 to 75% will have a lumpectomy. So that gives you a sense of how many women annually. United States alone, that doesn't count Canada, the UK, or the rest of the world, just the US alone, that's the number of women undergoing a lumpectomy, and up to 25%, some institutions lower, unfortunately some institutions higher, but re-excision. So it's tens of thousands of women each year having at least one re-excision. Sometimes you have to have more than one.
Yeah, and Dr. James, could you maybe talk about any trends you're seeing on the election of breast conserving surgery versus mastectomy, and if you see that ratio of patients evolving?
We're seeing now that so two things are, I think, allowing us to do more breast conservation. So most of the time, that's the preference. Both the surgeon and the patient want to preserve the breast if they can. One, the use of what's called neoadjuvant chemotherapy. So more and more we're identifying tumors where it's actually better to start off with chemotherapy first before surgery. What that does, especially for more aggressive tumors and higher stage disease, it actually shrinks down the cancer, allowing more women now to go from what would have been a mastectomy prior to chemotherapy to a lumpectomy after chemotherapy. So that's one strategy. The other strategy, the one I was mentioning that I just did earlier today and the case yesterday as well, is something called oncoplastic breast surgery, where you combine the lumpectomy with a plastic procedure. So typically when you're doing a lumpectomy, there's only a certain volume of tissue that you can remove before you're going to leave significant deformity to the breast. And once the tumor to breast size ratio becomes unfavorable, you have to recommend a mastectomy because you don't want to do a botched or poor lumpectomy procedure. Also higher rates of positive margin of re-excision. However, with the addition of the plastic surgical procedure, doing a reduction mammoplasty, breast reduction, allows you to take a much larger or generous volume of tissue. So I think because of these two things, we're seeing more and more women eligible for breast conservation. And these are all scenarios where it is vitally important to get negative margins right off the bat.
Maybe we'll touch briefly several questions here. We've been hearing about a shift towards value-based healthcare. Can you briefly describe your business model and the potential to deliver substantial savings for payers? How do you think this trend could impact the adoption of new technologies such as this?
Yeah, so this is the truth, right? So regardless of what happens with our political cycles or policies in healthcare, this fee-for-service model is coming to a close. And what's going to happen now is we're going to be compensated or reimbursed or incentivized for quality, right? For good outcomes, not just for doing things. So if you look at the system right now, here's something you might find shocking, that currently, if I have a positive margin and have to go back to do a re-excision, you get to bill again for a whole nother operation, right? It's a perverse, very odd incentive. Now, no surgeon I know would purposely want to, try to drum up business by having positive margins. It's also not a good thing for your reputation to have a very high positive margin rate, because patients will go elsewhere. So that there's nothing there. There's no conflict of interest there, but it's just an odd example of the fee-for-service system that we're in. What we're seeing now is we're seeing a shift towards this more, I don't want to say capitated, but accountable system where a breast center like mine may get funded a certain amount annually to take care of this patient population, right? And it's fixed, which means all those re-excisions and all those redos and inefficiencies are eating away at the bottom line. And the real incentive now is to find every way to make sure that it's just one operation as efficiently as possible with the best possible outcome that you can get. And the last thing I'll say about this is when we talk about the value-based healthcare, again, it's all based on outcomes. It's not just clinical outcomes. It's not just looking at, the negative margin rate and, low recurrence rates and things like that. It's also be looking at patient-reported outcomes. And that patient feedback is going to then have a direct impact on your bottom line. So you have the benefit, obviously, of not having a lot of waste in your system by using something like Otis, but the fact that your patients are having a better outcome, better experience, and better feedback in this value-based system is also going to be financially important.
Jeremy, can you briefly describe your commercialization strategy that involves targeting innovators and early adopters?
Yeah, certainly. So a lot of what Dr. James was just talking about fits right into that. So our commercialization strategy right now is exactly that ROI model. So if you have 1 in 4 patients coming back for a reoperation, studies show that reoperation costs about $16,000 on average. That's $4,000 per patient, cost that the healthcare system is bearing right now. And if we can reduce those, by 50% or greater, that's a $2,000 plus savings to the institution and to the healthcare system. So with the investment of our technology, we believe that high volume institutions that are doing, over 100 or 150 lumpectomies a year, they'll recognize a low cost per patient and a quick return on their capital investment for our technology that will make it kind of a no-brainer economically. And then there's all of the brand equity and patient attraction attributes that we talked about a little bit earlier. It's in addition to all the value-based care discussions we were just having, hospital margins already were being compressed. So, being able to attract patients and drive revenue through their system is a big win for them as well. So, to the surgeons that are already imaging savvy, that can adopt the technology quickly, that Dr. James talked about, and doing so at value-based care, high volume institutions that it makes economic sense for, is how we'll initially commercialize the product, the pre-AI product. Then we'll be actively pursuing, an additional reimbursement code for this review for our technology once we have the data from the clinical study that's demonstrating the clinical efficacy of the artificial intelligence. And we believe that's going to be really compelling as well, in addition to clinical outcomes, but also from an economic endpoint perspective.
And doctors, who do you think would be the early adopters of this technology?
Frank, I think you're muted.
That's a loaded question. We first must get the total FDA clearance. That's going to be an important milestone. I don't doubt that we'll get it. But the strategy in terms of who is going to be the first adopters, that's to a great extent going to depend on the big payers, I think. You're talking about the Minneapolis Mount Group, Universal. You're talking about Oncology Centers of North America, Cancer Treatment Centers of North America, the big institutions. If they act as the forerunners, that might speed up, especially community oncology services, because I think the mass of the devices is going to be sold to the community hospitals. And the reason I'm hesitating is that I see something else happening in medicine, and I'd love to hear Ted's view on this, in what I call the regionalization of specialty care. And how that is going to affect the whole healthcare scene is difficult to predict. It really depends on whether there are national healthcare plans. It depends on whether you have something like Medicare for all. It depends. There are so many factors, geographical factors. Because the truth is, patients do better when they can get their operations relatively close to where they live. So that they don't have not just the inconvenience, but the uncomfortable aspects of traveling for care. It's something I think about for Mayo, because Mayo is a very big center in Rochester, and not so big, but still pretty large centers in Jacksonville and Scottsdale. We depend on very big urban centers and large populations for the bulk of our patients. So I don't know that that question can be answered right now. But what Ted said about value-based care, outcome-based care, and outcome-based reimbursement is also going to be a driver. So, if we can democratize technologies like this, maybe we can help those community hospitals to survive. And again, one of my hesitations is I don't know what impact this COVID epidemic is going to have because of the morbidity, not just the mortality, in driving a lot of hospitals out of business. And I worry a great deal about what the overall economic impact could be, and therefore what the impact is going to be on acquisition of new technologies and new techniques. So I'm hesitating because I don't know that we can answer that question until some of these variables are satisfied.
It's interesting, Frank, because you raised so many good points there, in terms of the centralization and realization of care. And on one hand, I can see, if there's a designated center of excellence for breast care, they need to have this device, right? It may even be a requirement, if you were going to be designated as a center of excellence for breast care, to have some form of intraoperative margin assessment. But on the other hand, on the reverse of that, care locally is very important. And I've written about this before, that I don't think that, as much as I do believe in centers of excellence, I also think that we need to standardize best practices so patients who can get care at home can stay local. And again, one of the things to standardize the best practice in breast care would be having an intraoperative margin device. So I can kind of see both the major center and the local center benefiting from something like this. So I think the early adopters are going to be people who are focused on, what's best for their patient, value-based care, being a competitive player in a more, harsh financial market. So as hospitals are experiencing more financial strain, they may be looking for ways to bring in new revenue, to reach new market share, and being able to advertise something like intraoperative margin assessment for breast cancer may actually be the saving grace. So there might be a good return on investment for struggling institutions. So there's so many different factors or ways to look at that.
Completely agree, Ted. Excellent summary.
Yeah, and maybe just Denny, just to help folks, for the investors on the line, to frame what an early adopter market would look like for Perimeter. And at about just a 20% procedure penetration, Perimeter's annualized revenue from that high margin razor blade part of the equation would be about $50 million a year. So it's not a very, very distant or a very steep hill to climb to get to revenue numbers that can justify, a $500 million kind of company. So we're really excited about being able to penetrate that early adopter market, especially.
Who precisely will be the early adopters? That was one of your questions. Ask me in a year.
I have lots of questions coming in and a couple of questions to still ask you guys. So let's do Let's dive into that. So if I'm a family office, it's a major donor to a hospital, and I want that hospital to start using this technology, can I work with Perimeter's team to help accelerate this process?
Yes.
Yeah, certainly. That's one of the things we're trying to raise awareness for here. I'd say the way you can get involved in the Perimeter story is twofold. We're, as I mentioned earlier, we're publicly traded on TSXV under the symbol PINK. For those who can trade in Canada, it's 4PC for the Frankfurt Stock Exchange folks, and currently NWFFF for the US folks over the counter. So, we believe we're the most exciting open market medical device story out there right now. And that's a great way to get involved. And then secondarily, if you are interested in supporting research or supporting getting this technology into your local hospital, we're eager for opportunities like that, and we're working with charitable foundations every day to try to penetrate as many as we can. So we'd love for you to reach out afterwards and help us through that process as well.
Without the AI, what form of training does a surgeon needs to receive before using a device like OTIS, assuming they aren't part of the early adopter market?
Yeah, I can field that as well. So we have, it's effectively reader training to help folks interpret the images. So Perimeter over the years has developed an imaging atlas that is a reference case for any new potential user. And this would show different disease states and different types of tissue under our imaging and help them see what kind of characteristics they should be looking for as they're interested in adopting the technology. So regardless of whether how imaging savvy you already are or not, which, we heard that more than half are probably already pretty good. You can go through this training program to become an expert reader, and we would certify you prior to using the technology anyways.
140,000 women get lumpectomies per year in the US, a 25% redo rate, 35,000 women. Reducing this to a 5% redo rate, 28,000 women are spared distress, and at $16,000 per resurgery avoided times 28,000, that's $450 million per year of reduced burden on the US healthcare system. With such compelling stats, how soon until you can get the current FDA-approved device into the hands of surgeons?
Yeah, we are actively working on that right now. We expect to, do a limited launch early next year and really begin our commercial efforts in earnest, as we're ramping up a sales force and ramping up commercial operations, really. We'll keep that measured with a full-scale launch, call it in April next year, which coincides with our favorite American Society of Breast Surgeons conference that takes place every year. So really looking to hit the ground running and scale up at that point.
I'll just add that, this is an area that's always been of tremendous interest among breast surgeons. So I've been doing this now I've been in practice now at a training for about 15 years. And I've been going to the major national meetings almost annually. And every year, one of the major conversations is about margin control. What can we do for margin control? What is an ideal margin? What is acceptable? When do we need to re-excise? What are techniques that we can do to try to minimize? One of the most quoted articles came out of Yale looking at shave biopsies, which is a surgical technique to try to optimize margins intraoperatively. I mean, this is front and center, I think, for every breast surgeon in practice. So when I think about early adopters or enthusiasm to have a device like this, it's going to be very, very high. I haven't had a breast surgeon who I've met who hasn't, really struggled with how to minimize positive margins. And this has been a focus, I think, of every breast surgeon practice.
What are the sources of cash? What does your balance sheet looks like? Will there be a financing I can participate in?
Not currently. So we are, as I mentioned earlier, we just completed an RTO at the end of June, where we raised about $10 million Canadian in a concurrent financing We also acquired roughly 7 million in net assets from the shell that we merged with. In addition to that, we haven't talked about it yet, but the product development efforts on the artificial intelligence are funded by a non-dilutive research grant from the Cancer Prevention and Research Institute of Texas. So you may have heard of CPRIT. They're doing phenomenal things supporting cancer research, particularly in the state of Texas and in the Texas Medical Center. But you know, out of a pool of nearly 30 applicants, we were the only applicant in our cohort to receive a product development grant for this technology because it's that compelling. So that will fund our finalization of the artificial intelligence. And then, you know, along with the financing we've completed, we have about 14 million plus of warrants to be converted. So, you know, all of that combined, we have a really strong balance sheet plus access to capital that supports the burn for over 3 years. So really there's no financing to participate in. The way to get into the story is to do it via the open market.
Can this technology be used in other cancer surgeries or in other parts of the surgical workflow?
Good question. I think so the answer is yes. In terms of breast, there are thoughts about utilizing Otis during the biopsy procedure to verify that tumor has actually been removed to kind of improve the quality there. There are certainly potential applications in looking at lymph node metastasis in breast cancer and whether this can help to identify intraoperatively if nodes are positive or negative, which would be, again, phenomenal. And then there are other tumor types where, again, having intraoperative assessment would be important. So if you think about, you know, all of the negative ramifications for breast, if I told you about something like pancreas cancer, it's even more important because when you're resecting the pancreas, or let's say the distal esophagus for esophageal cancer, you may not have the option of going back, right? Because it's such a difficult exposure and so hard to get back into the area that if you have a positive margin, then you're just stuck. You have to give the patient radiation and hope for the best. So I think that breast, there's obviously a reason that it's a first test case, but there are other cancers where it's going to be as helpful, and in some cases, maybe even more helpful than even breast cancer. Frank, would you agree?
Totally.
Yeah, I understand that another company, Faxtron, successfully installed approximately 7,000 X-ray boxes in hospitals and cancer centers around the US and Europe to be used during breast cancer surgery. Jeremy, while used for a different purpose than Perimeter's technology, is this a logical proxy to think about Perimeter's opportunity in breast cancer? And doctors, are there other comparable technologies?
Yeah, well, I would defer both of those questions to the doctors, I think, to hear their response first. But
I'll just take the other issue of other technologies. The other technologies will have to be optical to have the resolution that this OCT tool has. And there's a problem with optical technologies generally. It's called the ballistic scattering problem, that light scatters. And that is a real problem in terms of signal to noise. There are techniques. One of the people who early on developed the theory for OCT application is a fellow by the name of Steve Bopart at University of Illinois. Steve is actually someone I know quite well, and he's been using infrared tools. But there are limitations to the use of infrared, which I think are going to be difficult to overcome. So right now, I don't know of any other technologies, from a theoretical standpoint even, that will be comparable.
Yeah, I would agree with you. I would say that the example of Faxitron in terms of just a comparable device getting into the operating room would be a very appropriate comparison in terms of potential cost and workflow. So we have a similar device, not from Faxitron, but again, it's a device that allows you to get an image of your specimen in the operating room. And just the benefit of being able to do that rather than having to send the specimen down to radiology and wait for it to be done on that unit and interrupting people getting screening. Just the practical benefit in terms of workflow is why you're seeing such widespread adoption of that in operating rooms. So I think you can make a like parallel with the Otis in terms of efficiency and quality and kind of moving things along in an operational way. So yeah, I think that would be a reasonable comparison for how well Otis would be adopted into practice.
Jeremy, can you briefly summarize the next steps and key milestones ahead for Primary Medicine?
Yeah, well, I think we've touched on a lot of them already. Obviously, we've got two major value creation streams that we're actively working on right now. So the commercial activities that you'll be hearing about early next year will be very exciting, and just building momentum from that perspective. But then we have a lot of clinical activity taking place between now and really the end of next year. So we've got a couple of exciting papers that are currently in manuscript that we hope to get published, showing results of the algorithm and showing results of the technology. So we expect those to come out this quarter yet. And then as we continue to accumulate studies from the Atlas AI project, we'll be further refining and zeroing in the efficacy of the algorithm, and we'll share progress to that, which will be exciting. And then we'll kick off the randomized control trial, which is part 2 of the Atlas AI project, sometime early next year, and really start building the clinical body of evidence for the algorithm specifically. And, that'll be kind of a key proxy for when we'll plan to get FDA clearance on the algorithm.
G, do we have lots of questions for you guys? Quickly, how long will the data collection process take in order to make the AI component intelligent and supportive of more hospital centers and surgeons?
Yeah, well, so the short answer is we will have the data that will be, kicking off the randomized control trial with very early next year, by the end of January. Then the beautiful thing about the regulatory approach to artificial intelligence and computer-aided diagnostics is they recognize that the more data that we accumulate, the smarter it gets. So, we'll be continuing to get hundreds more patients next year, and we'll continue to further train and improve the algorithm. So, we'll have a great starting point that reaches the efficacy we desire early next year, and we'll continue to improve from there.
How many shares currently outstanding, and what does the free float looks like? What price are the warrants accessible at?
Yep, so there are 38 million shares outstanding. The free float, about 40% of those are captured in a hard 18-month lockup, so not a single share of those can be traded. You have an additional, call it 10% that are escrowed pursuant to a value escrow. So that's, a little bit released over 36 months. And then we have everybody who participated in the June private placement was subject to a 4-month hold. So those have been completely locked up since then as well. So the float, while expanding now, is still really, really tight, given our number one shareholder has subjected themselves to an 18-month plus lockup. So pretty tight there. And then the warrants, we have about half of the value of warrants is accessible at $2 a share. And then there's a kind of a range from $1.20 to $1.92. So really all of the warrants are currently in the money. And are already being converted based on the levels we're seeing already. So, a lot of optimism about getting those converted and bringing additional capital into the company.
And maybe I'll pick one last question, and we will share the contact information of you guys later on, so people can directly contact you. If I understood correctly, you won't have FDA clearance on your AI-enabled device until late next year. Does that mean you cannot sell the device until then?
No, just to clarify, this is a confusing point. So we have FDA clearance on the imaging device without the artificial intelligence, and that is saleable. So that is what we will be selling early next year. Then, as we talked about pretty early on, then we'll get the clearance on the artificial intelligence, and that is really when the technology is democratized, and we're able to, quickly bring 100% of surgeons along the adoption curve with very little barrier.
Now, anything additional that you'd like to add, anybody, before I have some interesting comments? Then,
I'll just say that this is the last comment I'll say is, this is the holy grail of breast cancer surgery. We've always been looking for some way to get the information that we need at the time of the lumpectomy to make sure that we've actually done the complete lumpectomy. So that's why I've really been with the company from the start, because I know that this is going to be revolutionary for my field.
Great. It sounds very interesting, and I hope we'll have more discussions at our upcoming conferences that are online this year, obviously. And I just will mention, speaking of AI, I have to brag here with who we got coming at our next family office conference at the end of the month. We got the head of AI at the World Economic Forum. We have the head of AI at Boston Consulting Group, the head of AI at Levi Strauss, the head of AI at where am I? Microsoft, H&M, and other leading companies. So AI is going to be a major topic, as you can understand, at both our Canadian and US conference. And speaking of cancer, next week we're going to, my next session on October 20th, Tuesday, will be with an Israeli entrepreneur called Ofer Shalev. And they developed something interesting, destroying cancer cells without affecting surrounding healthy cells and tissues. They are basically injecting special material, and then they developed a machine. After they inject that, they put you in the machine. It heats up and destroys just those cells, because they're sensitive to different issues that normal cells aren't. So they managed to do it without hurting the cells. They are starting to their experiments with human beings, I believe, very shortly. So very interesting. If this will be successful, it's going, I think, to be a breakthrough as well. So it's been amazing. I'm honored to have the top of the US medicine world right here with us today. We have lots of questions. I've never had so many questions. I have to tell you, I've been doing 50 of those already, and it keeps on coming. So I'd like to thank you very much. Jeremy, you will write me exactly whose contacts we can share with everybody. We're going to send an email tomorrow morning with all the information. I'd like to thank you, Dr. Ted James, Dr. Prendergast, Jeremy Sobotta, for being with us today. And I hope we can have another discussion later on and keep on talking about this. It's absolutely amazing.
Thank you, Danny.
Pleasure was ours.
Stay safe, and see you soon.
All right, take care.
Thank you.
I'm not going to allow myself not to be in touch for so long.
Frank, let's definitely make sure. All right.
Bye-bye.